Hello, Namaste viewers. Welcome back to our channel PhysioHealer. Today we are going to discuss about introduction to flag system, screening for red flags in physiotherapy and some tips to remember the questions to ask while screening for flags while taking physiotherapeutic assessment. Basically, the flags model is a framework for identifying factors that may become obstacles in a patient's recovery and return to work following a musculoskeletal injury. The early identification of these obstacles assists clinicians and physiotherapists and other injury management parties to develop a plan to overcome them, minimizing the risk that the patient will develop persistent pain and long-term work disability. Flags can be split into two distinct categories basically, clinical flags and psychological flags. Clinical flags are common to many areas of health, for example, red flags, that is for musculoskeletal disorders, which are indicators of possible serious pathology such as inflammatory or neurological conditions, structural musculoskeletal damage or disorders, circulatory problems, suspected infections, tumors, or some systemic diseases. If suspected, these require urgent further investigation and often surgical referral. There are certain signs and symptoms that, when observed in a patient's examination or history, alert us to fact that something could be seriously wrong. In the case of musculoskeletal disorders, physiotherapists are highly trained to identify or rule out red flags. So, if you suspect any red flags, the patient must seek urgent medical attention, and it is better to send the patient to the department, that is emergency department, rather than the risk any permanent or life-changing pathologies. Recently, orange flags were added to the spectrum, and that represent the equivalent of red flags for mental health and psychological problems, alerting the physiotherapist to serious problems that could be psychiatric in nature and therefore require referral to a specialist in that field, rather than following the normal course of management for the mild mental health conditions such as anxiety. Orange flags can include excessively high levels of distress some patients may face, major personality disorders, some post-traumatic stress disorders, drug and alcohol abuse or addictions, or clinical depression. Psychological flags allow us to identify the aspects of a person, their problem, their social context, and how those factors affect the recovery and return to work process. The concept was introduced basically in 1997 by Kendall et al. And looked at the factors that identify patients who were at risk for developing chronic disability and did not recover as was expected for their condition. So these psychological flags enable us to work from a biopsychosocial model and give a framework for the assessment and planning. These flags are not a diagnosis or a symptom, but an indication that someone may not recover as expected and may need additional support to return to work. So these flags are often referred to as obstacles to recovery. So psychosocial factors determine outcomes such as activity levels and participation and work, but appear to be less relevant to the reporting of the symptoms. Now let's see some red signs of serious pathology. For example, cauda syndrome, fracture, tumor, unremitting night pain, sudden weight loss of 10 pounds over 3 months, bladder and bowel incontinence, previous history of cancer, and saddle anesthesia. Now let's see some examples of a flag color, the nature of the flag, and the examples of clinical signs to look for on assessment. Red flags include signs of serious pathology. The examples include cauda syndrome, fracture, tumor, unremitting night pain, sudden weight loss of 10 pounds over 3 months, bladder and bowel incontinence, and previous history of cancer and saddle anesthesia. Orange flags include psychiatric symptoms, for example, clinical depression and personality disorder. Yellow flags include beliefs, appraisals, and judgments. The examples are unhelpful beliefs about pain, indication of injury as uncontrollable or likely to worsen. It also includes expectations of poor treatment outcome and delayed return to work. Yellow flags also include the emotional responses. The examples are distress not meeting the criteria for the diagnosis of mental disorder, some worries, fears and anxiety of patients. Some pain behavior, for example, pain coping strategies is also included in yellow flags. The examples are avoidance of activities due to the expectations of pain and possible re-injury, and sometimes over-reliance on the passive treatments. Blue flags include the perceptions about the relationship between work and health. The best examples of these are belief that work is too onerous and likely to cause further injury. So belief that workplace supervisor and workmates are unsupportive, and due to that the patient may also experience some exaggerated symptoms. Black flags include the system or contextual obstacles. The examples of these are legislations restricting options for the return to work, conflict with the insurance staff over the injury claim. Other example is overly solicitous family and healthcare providers. Sometimes heavy work with little opportunity to modify their duties at work. Now what are these red flags? We are going to see this in detail in today's lecture. So these red flags are signs and symptoms related to the screening of serious underlying pathologies mimicking a musculoskeletal pain. So these red flags are specific attributes derived from a patient's medical history and the clinical examinations that are usually linked with a high risk of having a serious disorder like infection, cancer or a fracture. So these red flags are not diagnostic tests and they don't necessarily predict the diagnosis or prognosis, but are rather clinical prediction guides. So their main function is to raise the therapist's suspicion when they are combined. So basically these red flags are indicators of possible serious pathology such as inflammatory or neurological conditions, structural musculoskeletal damage or disorders, some circulatory problems sometimes, suspected infections, tumors or systemic diseases. So if suspected, these require urgent further investigation and often surgical referral. Red flag screening questions were developed to help detect serious spinal pathology. Specific red flag questions are not used consistently across guidelines and there is little evidence to support their use. There are 163 different items that could be considered to be red flags, all of which are subjected to interpretation. So because of these factors, the benefit of using red flags has been questioned. Yet a physiotherapist or clinician still need to determine if a patient's presenting condition is suitable for conservative management or if a referral is necessary. So despite a lack of consensus, the red flags are still considered the most reliable clinical indicator of potential serious pathology. The best example of common red flags are if the person's age is over 50 years, progressive symptoms, thoracic pain, past history of cancer, weight loss, drug abuse, night pain, if the patient is systemically unwell or the patient has fever and night sweats. If we think of evidence for the red flags, certain red flags have been shown to have good accuracy. For example, recent trauma and age over the 50 years is associated with a vertebral fracture. Similarly, a history of cancer and a strong clinical suspicion have empirical evidence of high diagnostic accuracy of malignancy. On the whole, the red flag screening for low back pain has not been used successfully. So these red flags generally have poor diagnostic accuracy. So lack of consensus is guidelines as to which red flags should be used or when the clinicians should act. Now let's see some research. According to the Cook et al., there are 4 key reasons why red flag screening has not been successful. So red flag symptoms do not rule out serious spinal pathology, but they do not identify it either. The clinical tests for the red flags do not have low negative likelihood ratios, which means they cannot rule out a red flag even when the test is negative. So there is great variability in how red flags are defined, which limits research and clinical progress. Most guidelines recommend screening for red flags and they encourage anyone who represent with the red flags to undergo extensive diagnostic testing even if only one symptom is present. However, at least 80% of the patients will have at least one red flag. Moreover, it is important to remember that true screening really only can occur in a preclinical phase when there are no outward symptoms of a disease, that is, before a physiotherapist would see a patient. Thus, our red flag screening is actually a management strategy that does not involve any screening in the medical sense. So, clinicians or physiotherapists are not screening for red flags, but rather they are managing the conditions that they see. And as Cook et al. Note, red flag findings are more related to the prognosis than to a serious pathology, for example, fracture or cancer. Alternative approach for clinical practice, it is still recommended that the health professionals use red flags to identify potential serious pathologies. Recent research focused on creating an alternative approach to red flag screening. A key aspect of this framework is a greater focus on the context of the red flag. So, a patient's entire history must be considered, and the clinician must ask for enough details to understand the context behind the answers to the red flag screening questions. For example, if the patient has history of cancer, important to inquire where the original cancer was. Breast, prostate, and lung would heighten the index of suspicion of metastasis in the spine. If the patient is suffering from weight loss, the unexplained weight loss is a cause for concern. If a patient has been on a diet or exercising more, the weight loss is to be expected, or if a certain new medications or pain are suppressing a patient's appetite. If the patient has night pain, many patients with back pain will complain of night pain. Important to find out more about the quality of this pain. So, if a patient who is able to get back to sleep will not generate the same level of suspicion as a patient who cannot get back to the sleep or has to get up to sit in a chair to get back to the sleep. Now, what is the framework of this red flag system? First, we are going to see the level of concern. So, the level of concern is considered. The framework encourages the clinician to not simply rely on one red flag, but rather to consider the context of the patient and the context of the red flags, including the symptom progression and comorbidities. Another important point of the framework is decision. The clinician or the therapist needs to decide if there is a level of concern. If there is none, the management can begin. If there is some concern, the clinician could consider a trial treatment but will need to monitor the patient over the period of time and revise the management whenever it is necessary. The red flags should be regularly considered and re-evaluated. It is not enough to simply consider red flags at the initial assessment only. If there are more concerning features, the clinician needs to consider their urgency. It is a medical emergency, for example, codic vena, that require immediate action or potential metastasis which could wait for a few days but still require urgent referral or not. Important point of the framework is pathway. The pathway helps clinician understand what they should do with the patient who present with the concerning features. This pathway is movable and flexible as shown in the figure. A patient can move between the pathways. Now it's time for some tips. Today I am going to tell you about an acronym that has been developed to help remember which areas to ask more about while screening for red flags. That is ABCDEFW. A stands for attitudes and belief. What does the patient think to be the problem, and do they have a positive or negative attitude to the pain and potential treatment? B for behavior. Has the patient changed their behavior to the pain? Have they reduced activity or compensating for certain movements? Early signs for catastrophizing and fear avoidance. C stands for compensation. Are they awaiting claim due to a potential accident? Is this placing unnecessary stress on their life? D stands for diagnosis or treatment. Has the language that has been used had an effect on patient's thoughts? Have they had previous treatment for the pain before, and was there a conflicting diagnosis? This could cause the patient to overthink the issue, leading to the catastrophizing and fear avoidance. E stands for emotions. Does the patient have any underlying emotional issues that could lead to an increased potential or chronic pain? Collect a thorough background on their psychological history also. F stands for family. How are the patient's family reacting to their injury? Are they being under supportive or over supportive? Both of which can affect the patient's concept of their pain. W stands for work. Are they currently off work? Financial issues could potentially arise. What are the patient's thoughts about their working environment? It's time to wrap it up. So, summarizing, it is important to consider serious pathology as a differential diagnosis. Clinicians need to consider how a red flag represents for a particular patient. Context is essential. Red flags should be re-evaluated at each and every session. It is important to identify which pathway a patient should be on to ensure that they receive the correct care in a timely fashion. If you have any questions or suggestions, you can write down in the comment section. We will try to reply as early as we can. Thank you for watching today's video. See you soon next time. Stay tuned. If you like today's video, don't forget to like, share and subscribe us.